بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أهلا وسهلا بحضراتكم. In case of the week 10, this is a case referred to my center at 28 weeks gestational age for a 4D scan. The first note was that the cisterna magna is effaced, and then we noticed that there is an open spina bifida with myelomeningocele starting at LV4 and extending into SV3. Here is a defect on 3D rendering with HD live. And here is the skin opening on 3D rendering. The vertebral bodies are otherwise unremarkable. There was marked hydrocephalus with communicating ventricles. This could happen not only with hollow prosencephaly but also with marked hydrocephalus. And you will notice also that the choroid is dangling and even extending into the contralateral ventricle. The corpus callosum was preserved yet sent out from the hydrocephalus. And here is a multiplanar imaging of the hydrocephalus. You will notice that the cavum is the corpus callosum is sent out. And you cannot notice here any fruit signs, lemon sign or banana sign. The normal spine has two parallel rows on sagittal view of echogenic foci with shadowing, with sacral tapering, and the height of the vertebral body is more than the intervertebral disc. The conus medullaris is seen above LV4 at 13 to 18 weeks, and above LV3 at 19 to 36 weeks, and above LV2 after 36 weeks. The linear probe will give you a chance for better visualization of the conus medullaris, filum terminal, central canal, nerve roots, with better characterization of normal variants such as cysts of filum terminal and ventriculus terminalis. On the axial view, you will see three echogenic ossific centers equidistant from each other, with the spinal cord hyperechoic circle hypoechoic structure with a central echogenic canal in the midline. The skin and subcutaneous tissues will also be observed in the both in the sagittal and the axial views. On the coronal view, you will see a railroad appearance. Its importance lies in the, to exclude the possibility of scoliosis, and you will notice also the normal lumbar widening. The skin and subcutaneous layers cannot be assessed on coronal view. How do you count the vertebral bodies to localize the conus medullaris or level of the lesion? By 16 weeks, LV5 is ossified. By 22 weeks, S2 is ossified. Most caudal vertebrae with a corresponding rib is T12. Upper pool of the kidney is at T11. Vertebral level on top of iliac wing is SV1. The lowest and most faintly ossified vertebra, and this is by far the most important thing, is SV4. This is an early third trimester diagnosis of Chiari II malformation, where the fruit signs have gone. No more bananas or lemons. Low risk for chromosomal anomalies. 3D was additive in detecting exact level and extent of the defect. This is important in prognosticating such cases. Also, it better displays the skin opening and helps in counseling parents. In such cases, watchful ultrasound for knee and ankle flexion is additive in prognostication, and they may last even up to 40 minutes in evaluation. Here is the banana sign, where you can see the normal cerebellum as a banana shaped. And here is the lemon sign, where there is bilateral concavity of the frontal bones, giving the skull an appearance in cross section similar to a lemon. The banana sign results from herniation of the spinal cord, leading to reduction of intraspinal pressure, allowing the hindbrain to be displaced downwards. The posterior fossa compartment becomes too small, and the cerebellum grows into this small compartment and becomes compressed like a banana. The lemon sign is seen on axial imaging, usually antenatal ultrasound, although antenatal MRI will also demonstrate this sign through the head, and relates to concavity, not just flattening of the frontal bones. Several diagnostic points should be remembered about this sign. First, significant anterior angulation for obtaining images of calvaria should be avoided, as fetal orbits could simulate a lemon sign. This sign usually disappears at more than 24 weeks, which may be due to the reduced pliability of the fetal calvaria with advancing gestational age, or an increase in the intracranial pressure with associated hydrocephalus. This sign may be rarely seen in normal patients, about 1% of cases, and in those with other non-neural axis abnormalities. Chiari II is a type usually involved in prenatal cases and is a congenital deformity characterized by displacement of cerebellar tonsils, parts of the cerebellum, fourth ventricle, pons, and the medulla oblongata through the foramen magnum into the spinal canal. In 95% of cases, it is accompanied by hydrocephalus and maybe myelomeningocele. Hydrocephalus and myelomeningocele. Associated anomalies: hydrocephalus from obstruction of the foramen of Magendie, syringomyelia, diastematomyelia, and tethered cord. Ventriculomegaly is relatively late onset sign. In most cases, 70% it appears in the late second trimester at 22 to 26 weeks and worsens thereafter in 80 to 90% of cases. The prognosis: in 40 to 20% of children with open spina bifida die within the 5 years of life due to shunt complications in a significant number of cases. If brainstem dysfunction relates to Chiari II malformation is present, the mortality rate rises even to 35 to 40%. Most disability depends on the level and the complexity of the spinal defect. Here is the prognosis with open neural tube and the closed neural tube defect. You will notice that the prognosis is by far worse for open neural tube defects as regards shunted hydrocephalus, ability to walk and dependability, and wheelchair dependency, walking and with support, and developmental delay, as well as neuropathic bladder and bowel dysfunction. You will always notice that the percentage for these abnormalities will be higher in open neural tube defect. The abnormal karyotyping can be seen in 16% of cases, especially when associated with other anomalies. The level of the lesions of progression of ventriculomegaly all will determine the prognosis. When LV, the level is at LV1, the hip function is hip flexion that is lost. Prognosis for ambulation and type of prognosis is indoor ambulation with long leg orthosis and crutches. At LV3, knee extension, it will affect this knee extension and the patient will suffer from community ambulation with ankle foot orthosis with or without crutches. When at LV4, like in our case, it will affect knee flexion with community ambulation with ankle foot orthosis without crutches, and when at LV5 it will affect dorsiflexion of the ankle with community ambulation and ankle foot orthosis without crutches, and if it affects LV1 is plantar flexion of the ankle, community ambulation without orthosis. The orthopedic problems for each neurological level is at thoracic level paraplegic, you will deformity commonly associated with scoliosis, kyphosis, and equinus. At mid-lumbar, you will notice that hip dislocation, internal and external tibial torsion, club foot, congenital vertical talus, ankle and hind foot valgus. Lower lumbar calcaneus, ankle valgus, hind foot valgus, sacral or normal cavo-varus foot. Lesions at higher level and larger segmental involvement are associated with severe clinical sequelae. Lesions at thoracic to L2, 50% associated with dysphagia. L3 to S1, bladder dysfunction. Associated limb abnormalities to be looked for. Open spina bifida is associated with hydrocephalus in 80 to 90% of cases. IQ is affected due to hydrocephalus and shunt complications. Fetal motor function is not predictive of future neuromuscular status. Independent ambulation is possible in lower lumbar and sacral lesions. Lesions above LV2, ambulation is less likely. Urogenital bladder dysfunction management: increase bladder capacity by using anticholinergics, avoid infections, and children to be trained for self-catheterization. Reproduction and sexual function: impaired the innervation of genitals and negative self-image due to incontinence. This results in decreased sexual activity in patients with spinal dystrophism. Obstetric management: finds the level and determines the extent of the spinal defect, as well as monitor for occurrence of hydrocephalus and assess fetal joint movements, trying to prognosticate the case. Genetic testing is indicated, especially if the lesion is not isolated. Consider delivery by cesarean section to avoid any trauma to and possible infection of the myelomeningocele during the transit through the birth canal. And here is the possibility of chromosomal abnormalities, that most of them are detected by karyotyping, and less of them are by array CGH, and more or less by exome or genome sequencing. Early neonatal surgery is associated with the best survival rates, but cannot reduce or prevent disability. Hydrocephalus represents a significantly negative prognostic factor. Prevention: periconceptional folic acid, the folate about 400 micrograms from supplementation and or fortified food starting 2 months before the planned pregnancy. Women who have not been supplemented their diet and who suspect themselves to be pregnant to begin taking 400 microgram folic acid daily and to continue up to 12 weeks. Differential diagnosis: mainly sacrococcygeal teratoma that lacks the skin defect and the cerebral signs. Take home message: always take careful views for the fetal spine, preferably in sagittal, axial, and coronal planes, or at least in sagittal and axial planes. Always try to access posterior fossa, though difficult in third trimester. Detecting the level of the defect help in prognosticating such cases. Watchful prognostication examination of fetal movements may last up to 40 minutes. The best prognosis is with ankle plantar flexion, followed by ankle dorsiflexion, knee flexion, knee extension, and at last hip flexion. Carefully assess fetal brain for ventriculomegaly or possible other associated anomalies. The fruit signs usually disappear at third trimester, so try to get fetal spine in best possible view, better anterior, by changing maternal position and waiting for a change in fetal position. Kind regards and see you soon. Assalamu alaikum wa rahmatullahi wa barakatuh. Dr. Amr Farouk.